Hello everyone, today you're going to learn a little bit more about acute myelogenous leukemia.
AML is a cancer of the blood and bone marrow, which is the spongy tissue inside of bones where blood cells are made. The word acute in acute myelogenous leukemia indicates the disease's rapid progression. It is called myelogenous because it affects a group of white blood cells called the myeloid cells, which normally develop into various types of mature cells. Most often, it moves quickly into the blood but can be spread to other parts of the body such as lymph nodes, liver, spleen, brain and spinal cord, and testicles. Risk factors for AML include genetic syndromes, example Down syndrome, inherited immune system problems, which is due to a reduced immune defense, family history, lifestyle-related factors such as alcohol exposure during pregnancy, radiation, exposure to chemotherapy, exposure to chemicals such as benzenes and household pesticides, a mother's age when the child is born, and fetal exposure to hormones. So what is the cause of AML? AML occurs when a bone marrow cell develops mutations in its genetic material. In AML, the mutations tell the bone marrow cell to grow and divide, which causes blood cell production to become out of control. The bone marrow then produces immature cells, which develop into leukemic white blood cells called myeloblasts. These abnormal cells are unable to function properly and, as a result, build up and crowd out healthy cells.
Patients may present with bone marrow failure, organ infiltration with leukemic cells, and/or both of them. Bone marrow failure symptoms are related to anemia, neutropenia, and thrombocytopenia. Neutropenia can occur due to a shortage of infection-fighting white blood cells called neutrophils. Thrombocytopenia is caused by a low number of platelets in blood. Anemia symptoms may be fatigue, dyspnea on exertion, dizziness, and organ infiltration with leukemic cells. Common sites are spleen, liver, gums, and skin. These patients usually have monocytic subtypes of AML, splenomegaly in the spleen, which is fullness in the left upper quadrant, gum infiltration, which leads to gingivitis due to neutropenia and thrombocytopenia causing gums to bleed, leukostasis, which is very rare, but can be a result of AML cancer cell blasts clogging up blood vessels and making it hard for normal red blood cells that carry oxygen to get to tissues.
To determine the prognosis, doctors use one's AML subtype and other information to determine prognosis and decide treatment options. Unlike other types of cancer, which use numerical stages to indicate prognoses and whether the cancer has spread, AML, there are no stages. The seriousness of the condition is determined by subtype, age, overall health, and results from other tests and procedures such as the number of white blood cells found in a blood sample. Did you know that the 5-year survival rate for children under the age of 15 with AML is 68%? The 5-year survival rate for teens ages 15 to 19 is 66%. Precautions and contraindications to be aware of are low blood cell counts and infection. The risk of infection is increased because chemotherapy damages the lining of the mouth and intestines, making it easier for bacteria to enter the bloodstream. Signs to look for are temperature of 100 degrees or higher, chills, coughing, sore throat, pain during urination, and diarrhea.
For behavioral, the child may report loss of appetite or feeling fatigue, report muscle weakness or pain, complain of stomach aches, or frequently urinate. Some general symptoms include weight loss, fatigue, fever, night sweats, and loss of appetite. Due to low white blood cells, infections may happen that never go away, such as fevers as well. Low blood platelet counts can lead to the client presenting with bruises or small red or purple spots on the skin, excess bleeding, frequent or severe nosebleeds, bleeding gums, and heavy periods if they have it. And low red blood cell counts due to anemia may cause fatigue, weakness, feeling cold, feeling dizzy or lightheaded, headaches, pale skin, and shortness of breath. Leukostasis can cause headache, weakness in one side of the body, slurred speech, confusion, and sleepiness. There are a lot of similarities in clinical presentation, but the main differences are that in infancy, the child may present with jaundice, have higher white blood cell counts, and extramedullary symptoms such as notable skin lesions called leukemia cutis. However, liver involvement usually dominates clinical presentation for infants. For childhood, a key difference is they talk about belly pain. They usually have shortness of breath while playing, and their acute symptoms develop over a few days and are usually for 1 to 2 weeks. Adolescents or young adults, usually first presenting symptom is myocardial infarction, and their acute symptoms last way longer, with fatigue and other symptoms lasting from weeks to months.
As mentioned before, the treatment of AML depends on several factors such as the subtype of the disease, age, overall health, and preference. Usually, medical interventions fall into 2 phases. The purpose of remission induction therapy is to kill the leukemia cells in the blood and bone marrow. This usually doesn't kill all the leukemia cells, so further treatment is needed to prevent the disease from returning. Consolidation therapy, also known as post-remission therapy or maintenance therapy, is a treatment aimed at destroying the remaining leukemia cells. This is important for reducing the risk of relapse. Both in these types of treatment, therapies such as chemotherapy, targeted therapy, bone marrow transplant, and clinical trials can be used. AML may impact the child's ability to perform academically. Learning problems are common due to absenteeism that results from hospitalizations, treatments, and treatment side effects. A statistic shows that children with AML report missing between 10 to 20 weeks of school in 1 year and might have to repeat grade levels.
Many of these functional implications can be a result of deficits in areas of development. For instance, in motor development, this can be stunted because of their joint pain and overall weakness from anemia and chemotherapy. In socio-emotional development, heightened feelings of anxiety, low self-esteem, and symptoms of depression can hinder their social participation, leading to isolation. Adaptive behaviors can be affected because of their small appetite as a result of chemo, negatively affecting their participation in eating. Bathing, personal hygiene, and grooming, dressing, etc. can all be affected due to their general weakness once again. Last but not least, their overall cognition can be affected negatively because of something called chemobrain. The chemicals used in chemotherapy can cause changes such as memory lapses, trouble concentrating and retaining information, difficulty multitasking, learning new things, and recalling common words. This makes it very difficult to participate socially and in school.
If the client is undergoing chemotherapy, there are several side effects that should be taken into consideration. These side effects include nausea, vomiting, fatigue, mild skin reactions, upset stomachs, and bowel movements. Because of the effect on healthy blood cells in the bone marrow, chemotherapy used for AML will lower the body's ability to fight infection for a short time. As OTs, we need to offer supportive care, which includes supporting the patient with physical, emotional, and social needs. We also need to help with the coping of fear of reoccurrence.
In working specifically with younger AML patients, the OT scope of practice focuses on several areas of occupation that include but are not limited to personal hygiene, social and emotional health, and participation in education and play. Performance skills that might be impacted for this population include motor skills, process skills, and social interaction skills.
Just as performance skills are affected, so are client factors. The primary client factors impacted include the following. The child's mental functions may be negatively affected because research has shown that children who have cancer frequently experience low self-esteem, anxiety, and symptoms of depression. Their sleep may also be affected, as their quality of sleep will decline because of their pain and their discomfort throughout the day. This also affects their energy and drive in return. In terms of movement functions, the child's gait can be negatively affected, as their weak joints and overall weakness can cause them to have a limp. Their neuromusculoskeletal functions can be affected in terms of joint mobility and joint stability. The child's cardiovascular functions can be negatively affected in terms of their respiratory system. If the cancer spreads to their lungs, it makes it very hard for them to breathe. Sensory functions are also affected because of their sensitivity. They have heightened sensitivity due to the anemia. Their muscle power is also negatively affected as their general weakness from anemia, chemo, and the disease itself take effect.
When working with younger AML patients, an occupational therapist may seek to address symptoms of fatigue through energy conservation techniques. Pain in bones and joints can also be addressed through pain management strategies provided by an occupational therapist. Exercise routines will help patients with AML retain as much muscle strength and endurance as possible. An occupational therapist can also assist parents and the family in developing routines for personal hygiene and other ADLs. Lastly, OT can work on coping strategies for the emotional health of each patient in light of a cancer diagnosis. Prior to working with AML patients, an occupational therapist must pick and choose a frame of reference to guide their interventions. Two possible frames of reference include the biomechanical frame of reference, which focuses on improving range of motion, strength, and endurance. The rehabilitative frame of reference is also an option for AML patients, considering it focuses on what the patient can do versus what they can't do, and the importance of identifying meaningful activities that the patients can participate in. It also focuses on energy conservation and environmental adaptations.
One standardized ADL assessment that is popular amongst pediatric hospital settings is the WFIM, a pediatric version of the functional independence measure. The WFIM is suitable for children ages 6 months to 7 years of age and up to 20 years of age with children with developmental disabilities. The WFIM measures the child's functional abilities in self-care, mobility, and cognition. With the WFIM, we can gather baseline data, monitor progression, and measure improvements in functional abilities from admission to discharge. A childhood cancer diagnosis means living with the disruption of their daily roles and routines. According to Mohammadi, children with cancer and who are receiving treatment for cancer tend to score significantly lower than their peers in participation, intensity, and enjoyment in ADLs. Thus, it is important for us as occupational therapists to encourage, monitor, and record our patients' engagement in their ADLs. A study by Hockenberry demonstrated that even 2 years after the end of cancer treatments, children with leukemia show gross and fine motor skill delay that may persist even when patients are considered healed. Due to the findings, we selected the BOT2 as our second assessment. The BOT2 uses goal-directed activities that measure fine motor and gross motor development in children and youth from 4 to 21 years of age. The assessment scales include fine motor control, manual coordination, body coordination, and strength and agility. By using the BOT2, we can gain a greater understanding of our client's motor performance and motor proficiency, develop a baseline data, and assess improvements in functional capacity as we progress through our interventions. Both assessments will give the occupational therapist unique insight into the client's current strengths, abilities, and areas in need of improvement to enhance autonomy and life engagement. When considering an intervention approach, consider where the child is in their cancer treatment. For instance, are they undergoing chemotherapy? Did they receive a bone marrow transplant? Are they anticipated to be discharged soon, or are they receiving palliative care? Each stage has its own unique set of intervention focuses. With that said, here are some of the common intervention themes that we found. Fatigue and energy conservation. As occupational therapists, we want to help them implement energy conservation techniques that will enable them to manage their fatigue and resume their meaningful roles and routines. For example, in dressing, we want to help them to plan ahead by gathering all of their clothing before they start, such as their shirts, pants, socks, shoes, etc. Have them dress at the edge of the bed, and we can also recommend them to wear clothing that's easy to put on and to take off. A second theme noted was prevention for secondary complications. Here, the occupational therapist may focus on prevention of secondary complications by implementing a low-impact yoga activity that promotes strengthening, range of motion, endurance, and balance. The third theme noted was that occupational therapists should encourage ADL participation. Thus, it is critical for us to promote participation in play as it promotes development in sensory, motor, and cognitive processing. As previously mentioned, individuals with AML are immunocompromised due to their medical condition and treatments. Thus, as occupational therapists, we need to find ways for them to continue their routines and occupations while also ensuring overall safety and well-being. Shaving may be an important occupation in a teenager's life. Thus, to minimize the risk of infection, we recommend a foil or rotary razor. Here we have a demonstration of how a client can use a foil razor to shave their legs safely. Notice how the foil razor glides on the skin easily, not leaving any nicks or scrapes on the skin. Recall that fatigue is a big common side effect that affects individuals with AML that can impede their independence, performance, and privacy during intimate ADL such as bathing and showering. Thus, to promote autonomy, it is recommended to introduce the client to a shower bench that will enable them to conserve their energy as they shower. As they conserve their energy, they will require less assistance throughout the activity, promoting occupational participation and performance that can enable the privacy that they deserve.
Luckily, there are many community resources that families can reach out to for help and support. The Leukemia and Lymphoma Society in the Greater LA region allows families to find support groups based off of location. They can type in their zip code to find the nearest support group. Their peer-to-peer support program connects current patients with other patients and families who have gone through a similar experience. This allows them to share their information on how to manage the disease. This society also offers financial support and food and nutrition classes. You can click on this link to find out more. Cancer Support Community LA also has a plethora of programs to choose from. They are focused on child, teen, and family programs and have education on coping skills through fun activities. They also have support groups and educational workshops. Children's Hospital LA also offers treatment for various types of leukemia, lymphoma, including AML. They have a life cancer survivorship and transition service, which is a direct clinical care and support for childhood cancer survivors, and it focuses on long-term solutions. And because of COVID, there's always online resources to turn to, such as cancer care. Here are the references that we used for this presentation. We hope you learned a little bit more about AML and how OTs can help with this population. Thank you for listening.